Hi, Adult Health 2. So this is your module one. This is all perioperative care. So that covers pre-op, intra, and post-op. This is going to be chapter 15, which is our pre-op patient. Here are your readings. This is just going to be, like I said, chapter 15. That's page 299 in F.A. Davis. There's also recommended reading of ATI, chapter 96. Here are our objectives. All right. So the perioperative phases. Perioperative refers to the whole thing. So it's pre-op, intra-op, which is while the person is actually um, in the OR suite, and post-op. Types of surgeries. Really, there's three primary types of surgical procedures: emergent, urgent, or elective. Um, Emergent surgeries are obviously surgeries that need to be done immediately to save a patient's life. These may be done to save a limb, perhaps, like if it was motor vehicle accident, or to save ability to function. So emergent surgeries have to be done right away, life or death, that sort of thing. Urgent surgeries, they just need to be done within 24 to 48 hours. So, pretty important, but we've got that window there. So this is just kind of to prevent permanent injury to the patient, maybe prevent death, right? But we've still got this 24 to 48-hour window. And then elective covers surgeries that may be necessary. So it's not just like getting your nose done or, boobs or whatever, right? It's not just those types of surgeries. Elective also covers things that are necessary, but they are not immediate. So they can be planned around the patient's and surgeon's schedules. Most surgeries done in the US fall under elective surgeries. Uh, all right. Also, when we are talking emergent surgeries, sometimes we need to hold off on those surgeries, even though it is an emergent situation. And that really is based on the fact that if our patient is unstable, okay? And we will talk more about that. This just talks about types of surgeries, reconstructive, cosmetic, minimally invasive. Also, telesurgery nowadays, right, is not that uncommon. Um, the priority for all areas of perioperative is safety, right? And with safety comes you have to have teamwork and communication. Like there's no way to go into an operating situation without teamwork and communication. So the governing boards for perioperative care include Joint Commission, World Health Organization, and then the Association of Perioperative Registered Nurses, or AORN. So these are governing organizations for um, operative procedures. So they can make recommendations, they can put out standards, things that we are expected to follow. Joint Commission, like we talked about in semester 6, if your hospital is Joint Commission certified, Joint Commission puts out recommendations, not mandates. But if you're Joint Commission certified, you are expected to follow those recommendations. So these things that these organizations put out, it's really nice that we call them recommendations, but let's be honest, you are expected to do them. So one of the things that Joint Commission has issued as a protocol is the wrong patient, wrong site, wrong procedure sort of protocol that we follow to avoid those happenings. The Joint Commission's universal protocol um, just help prevent these negative events from occurring in the first place. So there's 3 different sections to the Joint Commission protocol. There's pre-procedure verification. This is done in the pre-op area. We make sure that we have the right patient. We make sure that we're doing the right surgery on the right limb, all of that stuff. Procedural marking is done in pre-op as well. That's where we mark the site that that surgery is occurring on. The patient ideally is awake for this. If the patient is not awake, then it's a family member verification, but the surgeon does the marking, the surgeon does the verification, there's a witness, and the patient is hopefully alert and oriented for that. And then there is a procedural timeout. There's a timeout done in pre-op, and there's also a timeout done in intra-op. So once we've wheeled the patient back into the OR suite, into the theater, there is a procedural timeout there also. And that's probably the one that we're like most familiar with, to be honest. Here is the Joint Commission's Universal uh, Protocol Speak Up. That just popped up on the slide for you. Pre-procedure verification process. This just talks about going over everything with your patient beforehand, making sure that the verification band has the patient's correct name, correct date of birth, all their information. We do history and physical, we get the consent forms, all of the things, okay? It is at this time that we would address any discrepancies. Okay, so anything that maybe the birthday is off, right? Who knows? This just talks about marking the procedure site. Pretty self-explanatory, right? We don't want to cut off the wrong limb. And I say that kind of jokingly, but the fact of the matter is it happens. And can you even imagine? I mean, what a horrific event that would be. AORN worked with Joint Commission and WHO to come up with this comprehensive surgical checklist. This is a checklist that follows the patient throughout their procedure. Okay, so this checklist starts in pre-op, follows them into intra-op. This identifies like the timeout, all the pre-op, right patient, right site, all of that stuff. Those checklists can actually be tailored per facility. So it's not, your checklist is not going to be identical at every single facility, but it's going to have basically all the same stuff. Okay. Informed consent. Now, informed consent is really important for us as nurses because we witness informed consent. So, informed consent is when a patient autonomously and cognitively grants permission to a provider to perform a surgical procedure after considering all alternatives, benefits, and risks of the procedure. Although obtaining consent is not the role of the nurse, but that of the provider, make sure you note that it is not our job to get informed consent. It is the role of the provider. So the surgeon is responsible for getting that informed consent. The thing is, it is our responsibility to ensure that the patient has all the information needed to make that informed decision. What happens a lot is the doctor comes in, and doctors are much better about this today than they used to be. Even surgeons, they come in, they put it in normal terminology, they explain what's going to be happening, all the things. But doctors make patients nervous, right? And sometimes patients don't want to feel uneducated in front of the physician. And so the physician will go through his whole spiel, the surgeon explains all the things, asks the patient if they understand. Patient signs the consent, nurse witnesses it, and then as soon as that physician leaves the room, the patient is like, okay, I have some questions, right? And so the nurse needs to make sure that the patient really understands what they are signing. Um, we also are kind of the ones, if there is some sort of maybe educational deficit, right? Maybe our person is cognitively delayed, but not enough where it renders them unable to make decisions for themselves. That is kind of up to us to identify and make sure that the surgeon is aware of all of that. Um, Also, the better informed a patient is, the more likely they are going to be to follow post-op instructions, right? And there's a lot of instructions. We all know that at this point. We give people written instructions and all of that, but the better the better informed they can go into the procedure, the better outcome we're going to have on the other end. We also have to remember that the patient does have the right to refuse a surgical intervention. And this could be a case of maybe they're going to die even if they don't get this done, right? It is their right to refuse. And if that patient opts to not sign a consent, then they don't sign the consent, and then the procedure is not carried through. And that happens, right? So with the consent, there's consent for the procedure itself. This is going to be name of surgery, type of surgery, reason for surgery. We're going to identify who the surgeon is. We're going to identify the reason the intervention will benefit the patient. Also, believe it or not, on there is alternative options to surgery. Just showing that we've laid out all the things for the patient to consider. Also, potential outcomes if surgery is not performed, right? What can the patient continue to expect if we don't do this surgery? And then there is a separate consent for anesthesia, and then there is a separate consent for blood products. It is possible to consent for surgery for a procedure and not consent for blood products, right? Like, Jehovah's Witness is what just kind of typically comes to mind, but they do not believe in receiving blood products. Can we do a surgery if they can't get blood? Yeah. The other thing that we have available is called an autologous blood transfusion. Fair chance I'm saying that wrong, but that's where you donate blood before a procedure for you to then receive back should you need it during the procedure. So that's an autologous blood transfusion. And that just means that should you need blood, you have donated your own blood for you to receive. Okay. So that might be an option for somebody who is unsure, or for religious reasons does not want to receive other blood products. All right. Now, one of the things that we have to consider up until this point with consent is we were referring to a patient who's alert and oriented, cognitively able to consent, that sort of thing. But obviously, there are going to be times when the patient is unable to consent, right? So what do we do about that? So special considerations occur when the patient is not able to consent for care. These situations include patients who are cognitively impaired or who are cognitively aware but unable to physically sign. A patient who is deaf or speaks another language, minors, or emergency situations. In situations where the patient is impaired, a medical power of attorney may be established for consent purposes. Patients who cannot physically sign but are able to make their own care decisions may sign with an X. This consent needs to be witnessed by two people instead of just one, as normally required. If the patient speaks another language or is deaf, a hospital interpreter may be used. For purposes of consent, this is desirable over a family member. And we've talked about that before, right? We don't want to just grab anybody to be the interpreter. We need somebody who is certified in medical language to be the interpreter so that we know, or we can be better assured that what we are saying is being translated appropriately, right? Let's see. The book also talks about the benefit of using an anonymous interpreter, avoids any bias that may occur with a family member during translation. I I think this is such a good point because when you get talking with family members, there is always such an emotional aspect, and that is going to be relayed in translation, right? So if we can avoid that situation, it makes it much more of an objective situation, which is always what we're aiming for. Surgical consent for minors may be signed by the legal guardian. However, if the child is old enough to understand the care, the procedure should still be explained. So we would still, and whatever the age of the child is, I've never worked pediatrics in this sort of capacity, but you always talk to a kid, even if they're 5, you tell them what's going on, right? And that's just respectful. They're still a patient, and that's respectful. And then, of course, emergency situations, if there is no guidance available, um, the medical team is going to do whatever is medically necessary to save that person's life. This slide talks about advanced directives. It's kind of interesting that this was not really a thing until 1991, which to me, I know some of you probably weren't even born yet, but to me, 1991 doesn't feel that long ago, even though I'm kidding myself about that, but that's okay. But anyway, so the Patient Self-Determination Act of 1991 grants patients the right to determine and direct their care in times of medical emergency. They also have the right to create an advance directive. An advance directive defines a patient's wishes should the patient be deemed incompetent to express their wishes in a medical emergency. So this is like you get in a motor vehicle accident and you are not conscious and cannot tell people what you want. An advance directive outlines all your wishes, the things that you do want, you don't want, where you draw the line, that sort of thing. Facilities are required by law to provide the means and guidance to complete an advance directive if desired before surgery. So if somebody doesn't already have advance directive paperwork, the facility, and usually this is a caseworker or social worker who will come and help walk people through an advance directive. Within the advance directive, the patient may name a durable medical power of attorney, usually a spouse or an adult child, who is then designated to make all medical decisions should the patient become incompetent. The advance directive also allows the patient to express desires related to organ donation and end of life issues. So this is going to be when our patient kind of picks their DNR, DNI status, but it's other things too. It's like, do you want a feeding tube? Do you want to be maintained on vent support if that is necessary? There's lots of things to think about, and an advance directive allows people to kind of make those decisions before the situation presents itself. And then if you do not have an advance directive, what you have is various family members speaking for you. And I promise you, they will have differences of opinion on what you want or don't want. So anything that patients can put down in writing beforehand that takes that potential for discussion off the table way makes the whole process so much easier. This is again talking about informed consent. Surgeon is solely responsible for obtaining consent in the presence of the patient and one witness. That witness is usually us as the nurse. Family members or support persons may be present at this time. Informed consent for a scheduled procedure must be obtained before the administration of pain meds and sedatives or the induction of anesthesia. So again, our person needs to be alert and oriented. In addition to obtaining informed consent, the surgeon uses this uninterrupted time to ensure that all of the patient's and family members' questions are answered. The pre-op nurse. So many patients, this is what I was talking about earlier. Many patients admit to not reading the entire consent before signing. They also may realize they have questions that they weren't comfortable asking the physician about. So it is okay for us to correct common misconceptions and ease concerns of the patient family members or support persons. In addition to reviewing the consent form and validating patient understanding, nurses often serve as the witness to the consent. The nurse is witnessing the physical signature, not the information provided. Okay, so we are just saying that that is the patient's signature. We are not vouching that the physician explained the procedure in a way that the patient understood. We are not vouching for that. We are just saying that this person signed this paper. Okay. It is essential that the witness be with the patient as the consent is being signed. The nurse or other witness should never sign the consent form if they did not witness the patient signing the form. We don't want a family member being like, they're too weak to sign, let me do it for them, right? We don't want that. If that patient is able to sign, that patient needs to sign. And remember, even if they can't do a full signature, if they can only do an X, then we just get two witnesses for that. So whenever it's possible for it to be the patient, we want it to be the patient. The nurse is also responsible for documenting that a signed consent has been placed in the patient's chart. Okay, so we are the ones who are saying, yep, that consent is there. We saw them sign it. It's available. All right. There, we also have a timeout in pre-op. This is called a timeout or a pause for cause, which is kind of catchy and cute, right? We do these times outs. There, I don't know. I don't know what's happening there. That's right. But we do a timeout because surgical errors and wrong site procedures have happened. And can you even imagine? I mean, how horrible. You know, a lot of times you've probably altered this person's daily living for life. Okay, they're not going to be the same if we do a wrong site or wrong procedure. So I mean, that is very serious. So Joint Commission has this whole formal process requiring a timeout, I should say recommending a timeout twice within the procedure to make sure that these sort of things don't occur. The pre-op nurse, very much part of the timeout process. The timeout starts when the patient enters the surgical facility. Okay. On admission, the patient receives a wristband with their identifying information. The nurse and the patient review the wristband, make sure that everything is accurate. Okay. Before we move that person to the surgical suite, we're going to make sure we have all the correct information. The first responsibility of the pre-op nurse is to review the information on the wristband with the patient and have the patient name the procedure and site. This timeout is performed again by the circulating nurse on transfer to the surgical suite, and once more immediately preceding incision by the entire team. So we have verified that wristband now 3 different times. Okay. Surgeon is going to mark the surgical site and they are going to sign it and they use a permanent marker. Sometimes the surgeon will actually have the patient mark the site and initial the site, right? And that is just basically one more check mark, one more opportunity to make sure that we have the correct site, correct patient, correct procedure. components of the timeout. So, and this can kind of vary from facility to facility, but basically, our patient is going to state their full name. It needs to match what's on the band. We're going to use another identifier. Most of the time, this is going to be a birthday, but you need to make sure that that's correct. The year is correct, day, etc. Correct procedure and site. We're going to mark that site. And then, like we've said a billion times now, this is repeated again in the OR. Now, this is super interesting. This is acceptable patient identifiers. So the first two, name, date of birth, like we know those, right? Drilled into our heads. But you actually can also use the social security number. You can use a photo that's printed on the wristband. Some wristbands these days are going to have a picture of your patient, and that is acceptable patient. That's an acceptable patient identifier. You can also use the patient's address or telephone number. So on top of date of birth, social security number, photo printed on band, address or telephone number, that those are actually okay. To me, I would pay attention to this. This has NCLEX written all over it. Um, know that these are other options, okay? All right. So pre-op patient assessment. So we are going to go into all the things. Surgical patient requires a detailed medical history and assessment to ensure that the surgery is going to be safe, right? Pre-op nurse is responsible for obtaining and documenting the history on admission. Um, if there is a history on record, like if your patient is in inpatient facility, we're still going to review and document anything on the pre-op record. It is not uncommon for, as patients, as they're giving history and all the things, for other things to come up that were not previously recorded. That is not an uncommon situation. So even if we have a pretty extensive history, we're just going to verify. Okay, we just want to make sure that there's nothing that they decide to bring up out of absolutely nowhere that they had never mentioned before, right? Like they have 7 plates in their head or something and never thought to talk about this. So, and it happens. So our patient history, nothing really crazy. The one thing with surgery is we really need to know their last oral intake, and that is specific to procedures, right? Because we don't want to risk aspiration. Um, we don't want our person being sick, after anesthetics. We also want to know about piercings, implants, dental implants, anything like that. Um, Really, everything else is pretty much the same. Allergies, meds, over-the-counter stuff, supplements, medical surgical history. Um, oh, one of the other weird things that we would asked about specific to procedures is if they've ever had a negative response to anesthetic before, whether they came out fighting, right? If they woke up not calm and relaxed, but actually wanting to fight people, right? That is something we would want to know about. Okay. So take a look at that slide. There are a lot of conditions that increase surgical risk. I feel like these are pretty obvious. If your person has a history of cerebral venous thrombosis, right? Any history of blood clots like that is going to make us worry about potential for blood clots with our patient. Cardiac disease, diabetes, asthma, emphysema, COPD. So right there are respiratory things, right? And they are inflammation problems too. So we worry about that. Immune deficiencies. Immune deficiencies because is my person at increased risk for infection? Implants, pacemakers, right? All of these things, but I feel like that's really kind of self-explanatory. Your person unless emergent is going to be NPO for usually 8 hours before a procedure. That may vary. You know, infants and kids have some different rules that they use. And maybe if our person has diabetes, you know, we may not want them NPO for that long. You know, so there are some exceptions there. The pre-op nurse is going to document that last PO intake. So we're going to verify that with the patient. We're going to verify what it was, the time frame, all of that sort of stuff. Now this is a table 15.1. These are med considerations. This is page 308. So we need to know, should our person take their daily meds or not, right? Do we hold them? So antihypertensives in general are on a case-by-case basis, but we need to let anesthesia know, okay? A lot of these things, if anything pops up, you're working pre-op, okay? Um, anything pops up unexpected, we are going to let the surgeon and the anesthesiologist know. We want them to have the heads up, and then ultimately it is their pay grade to make the decision whether or not we continue a surgery or hold surgery. Um, One of the other things on this antihypertensives, beta blockers should always be given. Okay, we don't want our person stroking out on the table. Okay, but we also want to make sure that the surgeon and the anesthesiologist are aware that that person had beta blockers that day, because if their blood pressure starts to tank, we need to know what that person has on board. This table also addresses steroids, NSAIDs. We look at anticoagulants and antiplatelets. You know, most of the time we are going to hold off on anticoagulants. This recommends to taper the med at least 48 hours before the procedure. Um, we're going to want to know what our person was taking, when they took it last, and this is hopefully going to be part of their checklist of when they are planning the procedure, the physician goes over this with them. Okay, but be aware of what the recommendation is related to anticoagulants. This also talks about anticonvulsants and insulin. You know, we may want to hold some of our diabetes medications because we do not want our person to go hypoglycemic on us, right? We worry more about the complications related to hypoglycemia versus hyperglycemia. Hyperglycemia we can treat pretty quick, pretty easy. You know, as long as it's not something crazy, the side effects are not as detrimental as hypoglycemia can be. So take a look at these recommendations related to insulin. Again, that's page 308. Physical assessment of our person. So obviously we're going to do height and weight, but you need to remember with procedures, we're doing height and weight because this can determine our medications and how much fluids we use, right? So we're not just doing height and weight for the sake of height and weight. This may be dictating what medications we use, how much of the med we use, what kind of fluid needs our person is going to have. Also, if our person has a really high BMI, you know, I'm sure at this point we've all seen like My 600-Pound Life or whatever, you know, the sisters, you know, and they go in for for that bariatric surgery. That is special equipment to accommodate that size of a person. And so when we are taking in consideration height and weight, we are also doing this because we need to make sure we have adequate equipment available. This includes the operating table, transfer equipment, you know, gurney, all of this stuff. Okay. And then when we are positioning our patient, that is going to play into how we offload that weight on our patient, because you've got to consider too, and this is more of an intra-op conversation, but if I have somebody completely sedated and they're out, that weight, their muscles are no longer helping support any of that. All of that is just sitting on the table. And so we need to think about how that is going to affect skin breakdown, right? And we call, you've heard the term offloading, right? Same idea when somebody is on an operating table and you use cushions and splints and rolling and whatnot to offload pressure points so we don't get skin breakdown related to that table. So pre-op, back to pre-op, sorry. We also want to get a baseline set of vitals. I want to know what those vitals look like before we went into surgery. Now, with those vitals, do I kind of expect my blood pressure to maybe be a little up, my patient maybe to be a little tachycardic, right? They're being rolled into surgery. Are they going to be nervous? Yeah, for sure. So I'm not looking at anything to be like their normal, but I do want to get a baseline nonetheless. But I do expect that to be a little elevated. Okay. Systems assessment. This is pre-op. This is also going to be identified and gone over with the physician and or surgeon beforehand, before we even get to pre-op. If your person has cardiovascular issues, the surgeon may require a sign off by their cardiovascular guy, right? If they have COPD, they may require sign off from the pulmonologist, okay? Um, but we want to be aware of basically a full head to toe related to all these systems, because again, I want to return you to baseline. Post-op, I want you where you were, as close to pre-op state as possible. So that's why I go and get a baseline assessment on all of these systems. So CV, respiratory, neuro, liver, renal, I'm going to be looking at labs, right? Integumentary and GI. All right, so pre-op patient preparation. I want to make sure that my patient has good IV access. I'm going to want an 18 gauge. I can run blood products through an 18 gauge and not have to worry about it being too small. I also want it in a nice big vein. I don't want to try to stick that 18 gauge, not that this is going to work real well, but I don't want to stick that 18 gauge in a tiny little hand, right? Because if I try to run something through it, I'm just going to blow that vein, okay? Or it's going to be too big. So you want to make sure you have a good sight, AC, 18 gauge, make sure it's nice, sturdy, gonna work. The last thing you want to do is lose your line in the OR, right? Because then that's a whole other struggle. We don't want that. So make sure that your person has proper IV access, bowel and bladder preparation, depending upon what kind of procedure they're having. Maybe they had bowel prep the night before. Um, have to make sure that bowel is all empty and able to be operated on or visualized, whatever the case may be. If your person can get up and urinate, have them go pee, right? Or maybe they use a urinal in the gurney while they're waiting. They'll a full bladder is uncomfortable. It can also affect the neurovascular system, and we don't want that. We don't want our patient going through surgery with a full bladder. Um, we're going to have our person remove jewelry, prosthetics, clothing. Um, like we talked about earlier, we're going to talk about the presence of implants, surgical site preparation. They probably had to do some sort of bath with or scrub with chlorhexidine, probably the night before or morning of, right? And then there's further prep where they scrub the surgical site. This may also need to be the site may need to be shaved, right? If there's hairs, okay, we need to get rid of um those little hairs. We want to give any meds that need to be administered. This may be something to help your person relax, right? It could be maybe their normal meds, whatever. Let's see, we're gonna do any education with our person. Let's see, make sure I haven't missed anything here. Uh, venous prophylaxis refers to prevention of DVTs. Okay, so we are going to make sure that we are positioning our person correctly. Afterwards, this could be like SCDs, TED hose, anything like that, and then probably an anticoagulant of some sort. And we are going to talk about this with our person in pre-op. And also, of course, the most important for DVT prophylaxis is early ambulation, right? You know, both of my parents have had joint replacements, hips and knees and whatnot, and they get you up and walking like immediately, you know. And so you need to talk to your person about that, that this is what we're going to do. We're going to be up and walking immediately. All right. I'm having troubles with my slides. Hold on one sec. Let's see if we can get this to advance. All right, so we had some technical difficulties there, but we have moved on. Um, this is box 15.3, checklist of pre-op learning needs. Just kind of look at this. There's really nothing crazy on here. Um, this is just what we want to make sure that our patient is aware of. Okay. Um, Notice that we let them know who's on the surgical team, length of procedure, location of procedure. We talk to them about the pain scale, right? We need to educate them, even if they are their 85th surgery, right? We need to go over that 0 to 10 pain scale or the faces, whatever we're using. We talk to them about the anesthesia plan, post-op pain management. I know in semester 6 we talk about a pain management plan. We talk to them about this as part of pre-op because we want to know, and well, we want their physician to know really, like what are they okay with? I mean, there are people out there who are not going to want to take opioids. Maybe they have history of addiction. Maybe they just don't like the idea, right? So we need to know that. Um, Before we are needing that pain management, right? So that's something we talk about beforehand. We are going to talk about if there are any drains or dressings after the procedure, what that's going to look like, what that's going to feel like. Are they going to go home with that? What all does that entail? We're going to talk about walking afterwards, coughing and deep breathing. Um, Splinting the incisional area when coughing to decrease the pain. By that, they mean like, let's say I have an incision like left lower quadrant, right? By splinting, they just mean that you put pressure on that. That could be just using your hand, or it could be like holding a pillow to the site and just kind of putting a little bit of pressure on there. And then we are going to make sure that our patient is not going to be alone for the first 24 to 48 hours. We don't want that person by themselves, right? Even if they recover from anesthesia nicely and we're happy, you know, complications can occur, and we want to make sure our person's going to be with someone. Patient teaching to prevent pneumonia, early ambulation, cough and deep breathing, and of course, incentive spirometer. Physical preparations, we talked about the IV line. We are going to label that with the gauge, time and date of placement, our initials. We talked about bowel and bladder. We talked about skin prep, medications, and Also what transfer looks like, right? We're going to put you on this gurney. We're going to wheel you in. Here's what's going to happen. Afterwards, you're going to be wheeled out to pack you or whatever the case may be. We just want our person to have the most information possible because it just makes for a smoother transition. This is a safety alert, talks about transfer of patient to surgical suite. The pre-op nurse must ensure that the following have been completed before transfer to intraoperative care. So again, patient identifiers, physical preparations, confirmation of NPO status, documentation of med history, admission vitals, lab work, right? We want to know what's going on, especially kidneys, liver, that sort of thing. Electrolytes also matter. Allergy bracelet is visible. We haven't talked about that yet. What if our person has allergies? We need to make sure everybody is aware. Documentation of initial timeout. Copies of all the documentation are in the patient's file. Patient education with verbalized return of information. So that patient needs to be able to repeat back what we told them. And then family and patient questions answered. Okay. Nursing assessment, same old, same old. Vitals, physical exam, labs, last oral intake, confirm skin and bowel prep. Okay. A lot of confirming done with this, right? Everybody, this is just the checks to make sure that all these things are done. Nursing actions, page 314. Don't forget that the order in which the book lists your nursing actions is the order in which you should do them. Okay? So, number 1 was complete the pre-op checklist. So that's the first thing we're doing, complete the pre-op checklist. Then we're going to check for jewelry and prosthetics. Then we are going to make sure anesthesia and surgery knows about any implants. We're going to do our timeout. We're going to insert an IV. All right. Teaching. We talked about all of this before. What to expect related to the OR, prevention of post-op complications. This means like talking to your person about preventing pneumonia, right? We want you using your incentive spirometer. We want you up and walking. We want you making sure that that site is clean and dry, right? Prevention of post-op complications, and then managing post-op pain. That's our care plan, our pain care plan. What are we going to do? What are our options? The book talks about identifying like anything that has previously worked for your patient. If they like to watch TV to take their mind off things, all the things that we talked about related to pain in semester 6 and semester 5, right? So luckily a lot of that is review for us, but that is page 314 as well. All right, that concludes our pre-op. We made it under an hour. Very good. Oh, just barely over an hour. That's all right. All right. Tune in for chapter 16. Thank you.